Let's talk about benign bone tumors. Benign bone tumors, unicameral bone cyst, single, cameral cavity, bone cyst, seen at upper end of humerus. So UBC, upper end humerus, single cavity, filled with fluid inside. Upper end humerus, metaphysis. You must think about this lesion. If its cortex breaks, and with the movement of the fluid, this cortex moves up and down, tuck, 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 tuck. This is called as, similar to a door that you will see in India in Amitabh Bachchan movies. He will walk into a police station and will bang against the door, and then this door will move, tuck, 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 called as trap door movement. So, in unicameral bone cyst, it's called as trap door sign. When this fragment, the cortical fragment, falls to the bottom, it's called as fallen leaf or fallen fragment sign. Characteristic feature of unicameral bone cyst, UBC, is treated by curettage. This is a curette. This is a bone gouge to scoop out the bone. But the most common instrument used in orthopedics overall is nibbler. This is bone nibbler. So these are the things that will scoop out the bone from the cavity. So curettage, and put a bone graft, which is usually taken from iliac crest. You can aspirate and put steroids into it. You can aspirate or put sclerosins into it. So the bone grafting, if required, iliac crest, or aspirate, put steroids, or aspirate, put sclerosins. Unicameral bone cyst, upper end humerus. Coming to the next, aneurysmal bone cyst. Multiple septae are there, multicavitated and eccentric. So one cortex will not be involved as compared to the other, which is totally gone. It will have multiple trabeculae, breaking it into multiple cavities. Aneurysmal bone cyst is towards one side and is very commonly seen in tibia. That is the bone you should think about when you think about ABC. When you get an MRI done, these different compartments will give you a picture on MRI called as fluid levels. Treatment is more aggressive. You will do extended curettage. Whereas in UBC, curettage. UBC has a straw colored fluid, single cavity. ABC, aneurysmal, so hemorrhagic fluid. Both have pain, but ABC can have more pain and UBC can be asymptomatic. UBC first decade, ABC second decade. Humerus, tibia. Treatment, apart from extended curettage, you can embolize the vessel, shrink the size of ABC, which can help you to operate with ease. This is how you should remember. Unicameral bone cyst will be more contained inside, whereas ABC, although will be in the metaphysis before skeletal maturity, means the growth plate is still open, means the physis can still be there, but will balloon out like an aneurysm balloons the blood vessel. Aneurysmal bone cyst balloons the bone, expansion. So that is ABC. If you look at upper end humerus, metaphysis, you will think about unicameral bone cyst. But when you look about epiphysis, think about chondroblastoma. Chondroblastoma will be calcified because cartilaginous tumors, they have calcification. So it is epiphyseal with calcification, usually seen before skeletal maturity. And upper end humerus is the commonest site. So chondroblastoma, the commonest site is upper end humerus. But for upper end humerus, the most common tumor is unicameral bone cyst. So when you look at chondroblastoma of upper end humerus with calcification, it is also called as Codman's tumor. It's unlike the periosteal reaction which we did in the chapter of imaging, Codman's triangle. Codman's tumor is chondroblastoma. Codman's triangle, aggressive bone lesions or periosteal reaction, wide zone of activity. One very benign or a normal variant of a bone, also called as fibrous cortical defect, non-ossifying fibroma. It is the most common benign lesion seen in first decade of life. Involves the metaphysis. Key point: it will vanish on its own. Does not have any future repercussions. It's not pre-malignant. Whereas when we come to the bony outgrowths, if you look at the bone, this is the bony outgrowth. Osteobone. Overlying it is the cartilaginous cap. You know, the cartilage is not seen on x-rays. It is radiolucent. That is why when you will touch this osteochondroma, you will feel the bone, you will feel the cartilage. When you will click an x-ray of it, you will only see the bone. You will not see the cartilage. That is why they are large to feel, small on x-rays. They have got a directional growth. They usually grow away from the joint. They keep on growing till skeletal maturity. At skeletal maturity, they stop the growth. They are very commonly seen around the knee, around the shoulder. Osteochondroma, when they are multiple, they are called as exostosis. They are developmental abnormalities. They are developmental malformations. They are pre-malignant. Solitary osteochondroma, in less than 1% cases, can turn malignant into chondrosarcomas, whereas multiple, 6%. The ratio between the two is 1:6. When do you suspect it is becoming malignant? When the cartilage thickness is more than 2 cm, when there is a rapid growth, when it grows after maturity, when there is a loss of differentiation. How do you measure the cartilage thickness? Remember this: orthopedic imaging, most important, MRI. Treatment: they are covered with periosteum, and periosteum gives origin to it. So they are removed along with the periosteum, called as extra periosteal resection. Removal along with periosteum. Remember, they can give you this. Patient has night pain, relieved on taking salicylates or aspirin. Whenever they talk about night pain, relieved on taking salicylates or aspirin, think about osteoid osteoma. Osteoid osteoma is a diaphyseal lesion. It has a growth called as a nidus. Nidus is a lysis in the center surrounded by sclerosis. It will have both osteoblastic and osteolytic cells. Osteoid osteoma is in the cortex. CT scan is important for it. It can be treated by radio frequency ablation or by excision. Nowadays, radio frequency ablation is favored a lot. It's asymptomatic variety, ivory osteoma. Ivory osteoma, also called as compact osteoma or the hibernated osteoma. Ivory means white. Compact means condensed bone, white. Hibernated means shining white. They are seen on the skull. Incidental findings requires no treatment. When we look at these osteomas, they are white dots. But then come to something that involves the hand. Hand involvement in bone tumors is very rare. Metastasis, they don't go below the elbow and the knee. Primary tumors, which involve the hand and feet of the bone, are enchondroma. In fact, it's the most common tumor of bones of hand and feet. Enchondroma has a cartilage word in it, chondroma. So it calcifies. On biopsy, you will see hyaline cartilage. Enchondroma, treatment is extended curettage. They will show you phalanx with lesions. Think about enchondroma. Enchondroma can have multiple lesions. But when it's a solitary enchondroma, it is pre-malignant only in 5% cases. Multiple enchondromas, when there are only multiple enchondromas, nothing else, called as Ollier's disease, is malignant in 30% cases. Whereas one of the other malignant variety is Maffucci syndrome, which gives you multiple enchondromas, hemangiomas, phlebolith. Phlebolith means calcified superficial veins. I used a phrase here, malignant variety. Why? Because Maffucci is 100% pre-malignant. It's 100% pre-malignant. This is Maffucci. This image can come to you. Hemangiomas, calcified superficial veins, phleboliths, multiple lytic cavities or multiple enchondromas. M for Maffucci, M for many things. O for Ollier's, O for only enchondromas. Chondromas. Chondroma means cartilaginous lesions in the medullary cavity. They will present with a ring-like sign called as O-ring sign. They have popcorn calcification. Popcorn calcification can be seen in fibroadenoma of breast. It can be seen in hematomas of the lung. And it's seen in chondromas. O-ring sign. O-ring sign is seen in chondromas. Ring sign is seen in scapholunate dissociation. Rim sign is seen in chronic osteomyelitis. A rim around the lesion picked up on MRI. Rim sign. Rim sign, ring sign, O-ring sign. This can be asked to you. 3 causes: popcorn calcification, very commonly asked to you. When we look at the upper end of tibia, this is an enigma to many medical students. Sir, how do you differentiate between aneurysmal bone cyst and giant cell tumor? ABC is metaphyseal before skeletal maturity. Skeletal maturity means epiphysis fuses with the metaphysis, the physis disappears. Whereas GCT is seen towards the epiphysis after maturity. GCT is the only tumor known to mankind which can involve the joints. The joint can involve the joint. According to Robbins, this is the only tumor which can go and involve the cartilage. Giant cell tumor has two types of cells. The giant cells and the mononuclear cells. Mononuclear cells are the malignant cells. M for malignant, M for mononuclear. This is the only tumor which can go till the joint. It has soap bubble appearance on the imaging. Giant cell tumor enjoys to eat the bone. That's why when you will handle it, it's so soft, it crackles. Called as egg shell crackling. So it crackles, also called as egg shell crackling. This is one dictum you should remember. Tumor of the lower end radius is giant cell tumor till proved otherwise. It's a rule, remember that. This is a tumor, goes till the end, different examples. Going till the upper end of tibia, involving till the knee joint after maturity, or it can go right at the upper end of femur. Classically said that it should be within 1.5 centimeter of the joint. This is why it explains this can be GCT. So lower end radius, most commonly asked. Upper end tibia, upper end femur. One more dictum that you should remember. Lower end radius, most common tumor is GCT, but GCT's most common location, lower end femur. So when we talk about some love triangles in orthopedics, first decade likes E-wings, but E-wings is more common in second decade. Ameloblastoma involves the mandible, but mandible most common tumor is SCC. Lower end radius involves in GCT, but GCT most common location lower end femur. Remember that. Giant cells, mononuclear cells. Mononuclear cells are the malignant cells, but then there are tumors who will have giant cell variants, means they will have giant cells. They are lytic cavities like fibrous cortical defect or non-ossifying fibroma, commonest. Fibrous dysplasia, these are two fibrous lesions. Aneurysmal bone cyst, unicameral bone cyst. ABC, closest, these are two cystic lesions. Chondroblastoma, chondromyxoid fibroma, two cartilaginous lesions. Osteoblastoma, osteosarcoma, two osteogenic lesions. Brown tumor, hyperparathyroidism, blood degradation products in a cavity gives it a brown color, metabolic. So there are two cysts, two fibrous, two cartilaginous, two osteogenic, one metabolic. Commonest, fibrous cortical defect. Closest, aneurysmal bone cyst. How do you differentiate giant cell tumor and the variants? Now this is something which is a gold medal question. Giant cell tumor will have giant cells and will have mononuclear cells. It is said that it is the fusion of multiple mononuclear cells in giant cell tumor which gives it the giant cells. So the nuclei in a giant cell and the nuclei of a mononuclear cell is identical, whereas in all other variants the nuclei of both the cells will not be identical, they will be different. Remember this. Also remember one more lesion which is known to be changing the bone and being locally aggressive, just like giant cell tumor, is adamantinoma. Although adamantinoma, the treatment is simple: wide local excision with 3 centimeter margin. Whereas in giant cell tumor, the most common treatment is extended curettage. The second option in giant cell tumor can be excision. And this is more common in upper end of fibula or lower end of ulna. These are those areas which can be sacrificed. And the third option is excision plus reconstruction. You do this at lower end radius many times. But the number one treatment of giant cell tumor is extended curettage. So there are 2 locally aggressive tumors. One is giant cell, second is adamantinoma. These tumors are grouped in between benign and malignant. And here comes a golden line about giant cell tumor. Remember that 3% cases of GCT can have metastasis. One more golden line: GCT is more common in females. Bone tumors are more common in males. But there are 2 tumors which are more common in females. One is giant cell tumor, G for girls, G for GCT. Second is fibrous dysplasia, F for females, F for fibrous dysplasia. In fibrous dysplasia, which is a developmental malformation, the bone is replaced by the fibrous tissue. In fibrous dysplasia, the upper end of femur can be deformed like a stick of a shepherd, called as a shepherd crook deformity. The bone is replaced by fibrous tissue, so there is a hazy gaze. This hazy gaze gives it a ground glass appearance. Ground glass is not transparent. That's how it looks like. This tumor can have a lytic lesion at the upper end femur with sclerotic boundaries, called as a Rind sign. So fibrous dysplasia can lead on to a syndrome called as McEwen-Albright syndrome, which has 3 P's: polyostotic fibrous dysplasia, precocious puberty, pigmentation in which you have coffee colored spots, also called as café-au-lait spots. Langerhans cell histiocytosis. Histiocytes, their proliferation can destroy the bone. When they destroy only one area, it's called as eosinophilic granuloma. When they destroy the bone, the eyes, and the endocrine system, Hand-Schüller-Christian disease, which has got lytic skull lesions, exophthalmos, diabetes insipidus. When they destroy a human being, Letter-Sway disease, less than 3 years, fatal. Eosinophilic granuloma will have cells with groove nuclei. They have the solitary bone or lung lesions. In lung lesions, they are called as pulmonary histiocytosis. Skull affected, it will have beveled lesions, the sloping lesions. On biopsy, you have cells with tennis racket shaped granules called as the Burbeck granules. These granules have the tennis racket appearance, and then these are known for spontaneous resolution. In medical science, whatever disappears spontaneously Remember that. Spontaneous resolution. When you look at a vertebra and there are vertical striations, this is called as corduroy appearance, just like a pattern of print on a cloth, and jail bar pattern seen in hemangioma. This is an X-ray finding, can come as an image, but when you do a CT scan of that, you will see unequal sized dots called as polka dot pattern, a theory question, seen in hemangiomas. One more condition, very rare, but super at an orthopedics. Whenever they talk about sacrum, think about chordoma, not chondroma. Chondroma is cartilaginous tumors of the medullary cavity. Chordoma arises from the notochordal remnants at the extremes of the spinal cord. Sacrum very commonly involved. So whenever they show lysis of the sacrum, think about chordoma. Chordoma, second common malignancy of spine after multiple myeloma. Most commonly located in sacrum. They have cells which have vacuoles in them. Treatment is surgery plus minus radiotherapy. Remember, in orthopedics, we don't use radio because in ortho, we don't like radio. So that's how you remember that. When we choose ortho, we leave radio. So in ortho, rarely the indications of radiotherapy exist. Now coming to the malignant tumors. Synovial sarcoma. This is a tumor which is a misnomer, as it does not arise from the synovium. Then why is it called as synovial sarcoma? Because on biopsy, which happens to be the most important tool, you have the cells which resemble synovial cells. This is a tumor which has the translocation between chromosome X and 18, giving rise to a fusion gene called as SYT, means synovium, SSX, sarcoma. It arises near the joints. It's a biphasic tumor. It has epithelial and mesenchymal components. You usually have one malignant proliferation. Here, there are two. Treatment is surgery. Chordoma, synovial sarcoma. One of the very rare things. Books are quiet about it. MCQ world, they are super hit. These are two things that you should remember. When sometimes you take an X-ray of a patient, you repeat it after some time. The bone is not there, called as vanishing bone disease, also called as Gorham's disease. Angiomatosis of bone is one of the primary causes. Remember that. It's more of theoretical, but very commonly asked in PGI Chandigarh.